And I think our next speaker is joining us remotely. So if we're able to bring Dr. Gilmore in, I can introduce him. AV team, I'm kind of looking to, is Dr. Gilmore? Oh, hi.
Hi, Noel. Hi.
Hi.
Hi, all. It's a great pleasure to speak to you from a long way away.
Yeah, thanks. Thank you so much for joining us today. So let me introduce you formally to our group here. We've just kind of kicked off. So it's my great honor and pleasure to introduce our friend, Dr. Julian Gilmore. Dr. Gilmore, of course, really needs no introduction to an amyloidosis audience, but just to make this complete, he is the director of the National Amyloidosis Center in London, England, which is kind of the premier amyloidosis center, leading amyloidosis center in the world with respect to research and advancements and just so many things their group has done. And Dr. Gilmore is really a pioneer in this field and is responsible for so much of our understanding of this disease, him and his team. And of course, he's been a great friend to our Canadian community as well. He has supported us and he's always been there for us when we've needed something. And it's just been a great advocate. And it's not just us, of course. He does that for many other people, many other folks in different countries across the world. So I want to thank you, Julian, for all the support you've given us. And welcome. Thank you for joining us this morning.
Thank you very much, Leon, for the extremely kind introduction. Can I just check that you can see my screen and hear me?
We can.
Good. So it's a real pleasure for me to talk to you about new advancements in care of ATTR amyloidosis, and I'm going to mainly focus on treatment. I'll touch a little bit on diagnosis perhaps at the end, but as you said earlier, as you heard Noel say earlier, there have been huge advances, I think it's fair to say, in diagnosis as well as treatment, but I agree completely that I think we're probably just seeing the tip of the iceberg, and I'll touch on that. So these are my disclosures, and I'm just going to start by illustrating that all the treatments that have been approved in any form of amyloidosis are really designed to slow formation of new amyloid, if you like, and so to slow down the production of new amyloid, if you like, and the most comprehensive way that that's been tested is really by reducing the supply of the amyloid precursor protein. And in the context of ATTR amyloidosis, that's with gene silencers or potentially experimentally at least gene editing to knock down TTR protein. And then the other means of doing that, of slowing amyloid formation, is to actually, specific for TTR amyloid, is specifically to stabilize, as you heard from Noel, stabilize the TTR tetramer, prevent it from dissociating into monomers, and it's really the monomers that misfold and form amyloid fibrils. And we've got these two drugs that are stabilizers that have been shown to be effective in ATTR amyloidosis. And finally, and again experimentally, and again you heard from Noel, the very exciting possibility that we might be able to accelerate this natural rate of amyloid clearance, which is very slow in vivo in humans, but the aim really is to be able to accelerate that with these antibody therapies, and there are a few being tested. So the seminal study in ATTR amyloid cardiomyopathy is now quite a number of years old, but it was the ATTRACT study, which most of you will be aware of, in which 2 different doses of tafamidis were tested against placebo. And this was a study with hard primary endpoints, all-cause mortality and frequency of cardiovascular hospitalizations at month 30. And you can see there that the study met its primary endpoint. It reduced all-cause mortality in patients on tafamidis. They pooled the 2 doses of tafamidis, and tafamidis also reduced the frequency of cardiovascular hospitalizations. And on the panels on the right there just show you that with tafamidis, there is a slowing of the decline in 6-minute walk test and a slowing of the decline in quality of life as measured by KCCQ, compared to placebo. But as Noel touched on, I think what this study shows, and this is data from the open label extension of this study, is that there's still an unmet need. There are still patients who are progressing. There are still patients who are unfortunately dying with this disease. And so we need better treatments. The other thing that this specific slide tells us is that you can see that the patients on placebo in blue here never really regain the function they've lost. They're the ones that started tafamidis at month 30, the dotted line that you can see there, and they don't regain the function. So what that's telling us is we need, as Noel pointed out earlier, to diagnose the condition early, and we need to start treatment early in this condition. But even when we start treatment early, you can see the treatments that we have are not the panacea quite yet. Acoramidis is a new stabilizer, and it was designed on the basis of the T119M. It's a naturally occurring TTR variant which has been shown to protect against the development of ATTR amyloidosis, and that was developed some years ago by a company called Eidos. And in vitro, at least, acoramidis appears to achieve better stabilization of the TTR tetramer than tafamidis. This is a Western blot showing in vitro stabilization, and you can see that at the concentration that's achieved in vivo at when one gives the standard dose, one achieves better stabilization of TTR compared to tafamidis. And on the right is a TTR occupancy assay. It's a fluorescent probe assay, and you can see that there's more occupancy of TTR with acoramidis at that dose than with tafamidis. So in vitro, it appears to be a better stabilizer. And this is data from the ATTRibute-CM study, the phase 3 clinical trial of acoramidis, which shows that the increase from baseline in serum TTR. Now, the increase in serum TTR is thought to reflect or be a measure, if you like, of TTR stabilization. And you can see that the increase from baseline in serum TTR is higher in patients who received acoramidis than those who received tafamidis. Tafamidis was permitted 12 months after starting the treatment. And that the patients on the combination of acoramidis and tafamidis, so these were patients who started tafamidis after 12 months who were already on acoramidis, didn't increase the serum TTR further. So strong suggestions that you're achieving near maximal stabilization with acoramidis. This is the design of the ATTRibute-CM study. It's not dissimilar to the TRACK study. Patients with hereditary or wild-type ATTR amyloidosis, and there was a part A which was looking at change in 6-minute walk test distance from baseline at 12 months, and part B was at 30 months, followed by an open label extension, and patients were randomized 2-to-1 to acoramidis or placebo. And the primary endpoint was a hierarchical endpoint at month 30 of all-cause mortality, cumulative frequency of cardiovascular hospitalizations, change from baseline in NT-proBNP, and change from baseline in 6-minute walk distance. And these are the primary endpoint results. So the study met its primary endpoint. In other words, acoramidis benefited patients in terms of the primary endpoint. But I'd like to just focus on the third row there of all-cause mortality and cardiovascular hospitalization. So 58% of the ties in this hierarchical analysis were broken by the first 2 components of that primary endpoint. In other words, all-cause mortality, cardiovascular hospitalizations, which are, if you like, the hard endpoints that are worth measuring, as it were. And the drug was associated with an excellent safety profile. This is a more classical way of analyzing the data, if you like, looking at the composite of all-cause mortality or first cardiovascular hospitalization. And you can see again here a significant difference between patients on acoramidis and placebo, with the curves beginning to diverge at 3 months and steadily continuing to do so through 30 months. And there was a 36% reduction in the composite of all-cause mortality and first cardiovascular hospitalization, with a number needed to treat to prevent one of these events of 7. And there was a 50% reduction in annual cardiovascular hospitalization frequency, with a number needed to treat to prevent a hospitalization of only 5. So pretty impressive results. And I think the cardiovascular hospitalization is not to be underestimated in some of these patients. I quite often hear, as I'm sure you do, from patients, "Doc, I don't necessarily want to live that much longer, I just want to live better." And I think being able to reduce their hospitalizations is potentially very, very important. We know that the NT-proBNP rises in this disease if it's untreated, and we know that a rise in NT-proBNP is associated with mortality. And what you see here is that acoramidis attenuated that rise. And similarly, the panel on the right, you can see that the walk test does decline, but at 30 months, there was a very significant attenuation of that decline, with a 40-meter difference between the patients on acoramidis and the patients on placebo. So a very substantial difference at 30 months in terms of the loss of 6-minute walk test distance. This is quality of life, and you can see again that acoramidis favored or had a meaningful effect on quality of life compared to placebo. But the panel on the right tells you that nearly a third of patients actually reported an improvement at month 30 in quality of life compared to how it was at baseline. So some patients getting better. This is data from the open label extension out to 42 months. One criticism of the ATTRibute-CM study is that it didn't meet significance in terms of mortality alone at 30 months. And the main reason there is that it was a very different group of patients that were treated in this study compared to ATTRACT. And just to give you an illustration of that, the patients on placebo in ATTRibute-CM actually survived longer and better than the patients who were treated in ATTRACT. So with ATTRibute-CM was treating a less severe group of patients, an earlier group of patients. And what this open label extension shows us is that when you get out to 42 months, there is a very significant difference in survival between those on continuous acoramidis and those who transferred to acoramidis further down the line at month 30. So again, a mortality benefit associated with the drug. This is a sub-study, a cardiac MRI sub-study that we conducted in our center. It's a pretty small sub-study, and I need to acknowledge that to start off with, but I'd like you just to focus on the panel at the bottom that says that says ECV that you can see here. And the extracellular volume by cardiac MRI, we believe, is probably the best way, if you like, to this panel here. So the best way to measure the actual amyloid burden in the heart. And what we also know is that a reduction in extracellular volume of more than 5% is associated with survival benefit. And what we saw in the study, in this small sub-study, was that no patient on placebo had a reduction in extracellular volume of more than 5%. But 3 out of 24 patients in the treatment group, acoramidis group, had a reduction of that magnitude. So certainly a suggestion in terms of mechanism that some patients are actually getting into an equilibrium where they're probably making amyloid less quickly than they're getting rid of it, and some patients are actually regressing, as it were. This is the change from baseline in serum TTR. And you can see an increase. There was an increase by day 28 of 9.1 milligrams per deciliter, and that was sustained in patients receiving acoramidis across the 30 months. A post hoc analysis looking at change in serum TTR is shown here, and on the right you can see that what this demonstrates is that the patients who had the greatest increase from baseline in serum TTR basically did the best. And using logistic regression modeling, we were able to show that for every 5 milligram per deciliter increase in serum TTR at day 28, that was associated with a 31.6% reduction in all-cause mortality through month 30. So perhaps we will be able to start using serum TTR as a biomarker to, in conjunction probably with various other biomarkers, to tell us whether patients are responding to treatment or whether they're doing well generally. So I'm going to turn my attention to the gene silencers, and you will be aware that most of the gene silencers, or the first generation and second generation on the left two panels and right two panels respectively, have largely been tested in polyneuropathy, the gene silencers. And they've all these studies have shown very similar things, really. The worsening neuropathic scores in patients on placebo compared to those that either remain stable or possibly improve a little bit or decline a little bit in patients on the various treatments. So definite evidence of clinical stability or even some improvement in patients' neuropathy with ATTR, hereditary ATTR amyloid polyneuropathy. The first of those studies, the Apollo study, there was a post hoc analysis conducted in those with a mixed phenotype, so who had evidence of cardiac involvement. And this shows you that patients on patisiran had a reduction in the composite rate of all-cause hospitalization and mortality, and cardiac hospitalization and all-cause mortality. So early evidence that these drugs not only benefited the nerves, but in patients with mixed disease also benefited the heart. The Helios B study was really the first hard outcome study of a gene silencer in patients with ATTR amyloid cardiomyopathy. This is the study design. So again, patients with wild type or hereditary ATTR amyloid cardiomyopathy. More advanced patients were excluded. They were randomized to vutrisiran or placebo, and the primary endpoint was a composite at 33 to 36 months of all-cause mortality and recurrent cardiovascular events. And you can see the secondary endpoints there. And again, the study was followed by an open label extension. And this study met all of its 10 primary and secondary endpoints, and there was a very significant reduction in all-cause mortality at 42 months, so a bit further out from the primary endpoint measure of 36 months, as it were. So again, the drug unequivocally benefiting patients, and you can see on the panels on the right there, again, a slowing of the decline of walk test, a slowing of the decline in quality of life, and an attenuation of that rise in NT-proBNP that I mentioned earlier. I think we should say that this is a study, this is a graph from a paper that we published very recently, just showing the improvement over time. And I think you ought to concentrate really here on the placebo patients. So the dotted lines are the placebo patients. And you can see that the placebo patients are doing better and better across time. But the treatment effects are very similar across these three studies. And in this analysis that we did, we were unable to show superiority, as it were, of one drug over and above the other. Basically, what this analysis showed is that all the drugs appear to be beneficial, and there isn't sufficient evidence to suggest that one drug is necessarily better than another, as it were. And I think what I would say is that our current drugs, if you like, don't either stabilize TTR completely. I told you earlier that acoramidis appears to potentially stabilize in vitro, at least, TTR more effectively than tafamidis, but it doesn't stabilize TTR completely, and nor does vutrisiran or patisiran, or indeed the antisense oligonucleotides, nor do they reduce serum TTR to nothing. So one still, if you like, has some substrate to make more amyloid. And what we know from other types of amyloid is that the more we knock down the precursor protein, the better the outcome. And on the panel on the left there shows you patients with AL amyloidosis, and these are patients who achieve a complete hematological response equivalent to 100% knockdown, if you like, and they do the best. Patients who achieve what hematologists call a VGPR, equivalent to around 90% reduction in the amyloid forming protein, they do pretty well. Those who achieve 50 to 90 do less well, and those who achieve less than 50% knockdown do even worse. And the panel in the middle is in AA amyloidosis, and you see exactly the same thing. This is the relative risk of death in relation to SAA concentration. SAA protein is the protein that makes amyloid fibrils in AA amyloidosis, and you can see that the more the SAA is knocked down, the better the outcome. The relative risk of death goes down as SAA is knocked down by anti-inflammatory therapy or whatever therapy it is that's treating the underlying inflammatory condition that gives rise to AA amyloidosis. And in the panel on the right, you can see that the same trend is certainly emerging in ATTR amyloidosis, although I think it's important to say that the data are less mature and there isn't conclusive evidence at this point in time that greater knockdown of TTR translates into better outcomes. And I would just like to highlight from our experience with SAP scintigraphy that amyloid is a dynamic process. And this is a patient on the left. These are anterior whole body SAP scans. And this is a patient on the left here who presented with a massive liver and spleen, this black bit, and you can see amyloid in the bones. This is a patient with a large AL amyloidosis load who received chemotherapy for his AL amyloidosis and achieved a hematologic complete response. And less than a year later, you can see on a repeat anterior whole body SAP scan, a marked regression of amyloid from the liver. The liver there is really back to normal, and some regression, very marked regression from the spleen, albeit not to normal. There's still amyloid in that spleen. So marked regression of the amyloid. The patient relapsed, and after the hematological relapse, an increase in the light chains, you can see that the amyloid is building up again in the patient's liver and spleen. And unfortunately, this patient was not treated in a timely fashion. And you can see again the amyloid building up back towards where the patient initially presented. So just showing you how dynamic this process is. And on the right is cardiac MRI. Unfortunately, SAP scintigraphy, this imaging technique, is no good for the heart. And Mariana Fontana in our center really developed extracellular volume as a measure of amyloid burden in the heart, which I mentioned earlier we used in the acoramidis study. And what she was able to show in AL amyloidosis is that in order to achieve cardiac amyloid regression, one needs to achieve either a complete response, preferably, or at least a very good partial response, which I told you earlier is equivalent to about 90% knockdown of the amyloid fibril precursor protein. And so perhaps the same is true in ATTR amyloidosis. Maybe we need better knockdown to achieve amyloid regression. And I think it's worth bearing in mind that if you go from 80% knockdown to 90% knockdown, it feels like a small gain, doesn't it? but actually that equates to having 50% less TTR in the bloodstream available for new amyloid formation. So you're reducing the substrate available for amyloid formation by 50% with that tiny increase in knockdown, if you like. So the way that I think about it, and I would like you to focus on the three panels on the right. Here's the rate of amyloid production in the absence of treatment, and here is the rate of amyloid clearance, which is invariably slow, but does vary from one patient to the next. And the rate of production in the absence of treatment, it always exceeds the rate of clearance. So the amyloid burden, shown by the thick blue line, invariably builds up in the heart or builds up. If you imagine a drug that reduces the rate of amyloid clearance, as you can see here in this panel, then in a patient who has a reasonable rate of amyloid removal, you might get them into an equilibrium where they're getting rid of amyloid more quickly than they're making it. So overall, their amyloid burden is diminishing. But if you have a patient like here on the right who has a slow rate of amyloid clearance, even if you slow the rate of amyloid formation quite substantially but not completely, they might still be increasing in terms of their amyloid burden. It will still be increasing. But obviously, if you could stop amyloid formation even more completely, even in a slow amyloid regressor, as it were, you might get them into an equilibrium like this, where their amyloid burden is diminishing. And so, what about the potential for gene editing, a novel technology to address this unmet need? Nex-Z, or Nexiguran-Ziclumeran, is a one-time infusional gene editing therapy, which is administered by intravenous infusion and is taken up by the LDL receptor on the surface of hepatocytes, and essentially releases its cargo into the hepatocyte and then gets into the nucleus and basically causes what we call a double strand break in the TTR gene, specifically in the TTR gene, which stops production of the TTR protein. And quite recently, we conducted a first-in-human study of Nex-Z, and it was a two-part open-label multi-center study in patients with both hereditary ATTR amyloid polyneuropathy and ATTR amyloid cardiomyopathy. 72 patients were treated in total, 36 with cardiomyopathy and 36 with polyneuropathy, and it was a two-part study, a single ascending dose phase and then a dose expansion phase. And obviously the primary objective was really to evaluate safety, tolerability, PK and PD, the latter by measurement of serum TTR levels. And these are the serum TTR levels in the cardiomyopathy group on the left and the polyneuropathy group on the right. And you can see that regardless of baseline TTR concentration, Nex-Z led to consistently low and sustained reductions in serum TTR. And the residual serum TTR concentration at day 28 was around 17 micrograms per liter, and that was sustained through to month 24 in the polyneuropathy patients, and that is equivalent to a knockdown of about 91%. So very encouraging results in terms of TTR knockdown. What did that mean for the patients? Well, the cardiomyopathy patients in this study actually had very advanced disease. 50% were NYHA class 3 enrollment, and more than 30% had hereditary ATTR amyloid cardiomyopathy, which is known to be associated with a more aggressive clinical phenotype, including 2 homozygotes. And what you see in these panels here is that there was stability across 12 months in the biomarkers. There was stability or potentially even some improvement in KCCQ and stability in terms of the walk distance or the change in walk distance from baseline. So certainly encouraging evidence. It's an open label study. It's not controlled. We need to be cautious in our interpretation of these data, but certainly encouraging evidence that this drug might be very effective. In terms of the neuropathy patients, what were the effects on the neuropathy patients? And this is a waterfall plot just showing you the change in mNIS+7 from baseline to month 24. The patients were followed to 24 months, and this was recently reported, showing that the vast majority of patients, in fact 72% of patients treated with the drug, had a clinically meaningful improvement in their mNIS+7, which is designated as a reduction of greater than 4 points in their mNIS+7. So most patients showing improvement in neuropathy, and a group of severe cardiomyopathy patients showing stability. What about safety? Well, the safety in this study was actually very encouraging. The main treatment-related adverse events were infusion-related reactions, but they were all reversed without clinical sequelae. There were a few patients who developed abnormal liver function tests, and some of you may be aware, and I think it's important for me to say, that the Magnitude phase 3 clinical trial has currently been halted because a patient developed grade 4 liver enzyme elevations. So although we didn't see any important liver elevations in the phase 1 study, there has recently been an important liver elevation, and that study has currently been paused while the company and the sponsor looks at mitigation strategies. But in this study, the safety was certainly very, very encouraging. And I should say that there are now about 500 patients who have been treated with Nex-Z. This is the phase 3 clinical trial that I was talking about, Magnitude. It's patients with ATTR amyloid cardiomyopathy, randomized 2-to-1 to Nex-Z versus placebo. It's an event-driven study, and the primary endpoint is the composite of cardiovascular-related mortality and cardiovascular-related events. And you can see the secondary endpoints there. There is a third-generation RNA interference therapeutic from Alnylam, which looks extremely exciting. So this is a drug called nucresiran, and these results from the phase 1 study were reported about a year ago now. And what this study showed is 97% reduction in serum TTR with this drug, which is given at 6-monthly intervals. So this looks, again, an extraordinarily encouraging drug. And we're expected to have phase 3 clinical trials in both cardiomyopathy and polyneuropathy, if not by the end of the year, by early next year. So again, drugs which improve the knockdown more and more. What about the combination of a stabilizer, for example, and a knockdown agent? It makes logical sense, doesn't it, to knock down serum TTR and then stabilize whatever remains. And having said that, and I think it's important to say at the moment, we don't have hard evidence to say that combination therapy is better than monotherapy. There was a suggestion possibly in Helios-B, and this is data from Helios-B, that the combination may have been beneficial over and above monotherapy, but the study was not powered to show that, and so we can't conclusively say that that is the case. We have CardioTransform, which should be reporting in about a year's time. Most of those patients in that study will have been on tafamidis from the start, as well as the intervention versus placebo, as it were. And that may answer the question of whether monotherapy or dual therapy, combination therapy, is actually better. So I think more information needed to answer that important question. Finally, I'm going to turn to what we talked about at the beginning, which is drugs to remove existing amyloid, accelerate that slow rate of natural clearance that I've been talking about. So in other words, attacking this side of the equilibrium to try and accelerate amyloid clearance. We've had a long interest in drugs to clear amyloid, and some years ago we developed a drug, an antibody directed against SAP, which is a minor constituent of all amyloid fibrils. And we were able to show in a mouse model of AA amyloidosis and then subsequently in patients rapid removal of amyloid from the liver and spleen after administering this anti-SAP antibody therapy. The phase 2 studies were designed to look at whether we could remove or achieve the same rapid removal of amyloid from the heart, and unfortunately that didn't occur, and so the drug was dropped. But nonetheless, it was a proof of principle that if you can get a drug, an antibody to amyloid and elicit an immune response to amyloid and accelerate removal, you can get clinical improvement. And since that time, there have been a number of drugs that have been developed by various companies to try and remove existing amyloid. This is data from the phase 1 study of Neuroimmune 006 that was reported in the New England Journal earlier this year. The studies or the drug is now owned by Alexion, and what you can see here is encouraging results in terms of NT-proBNP and encouraging results in terms of extracellular volume on cardiac MRI, with the results beyond 12 months really showing some very marked drops in some patients on extracellular volume, which are drops that one wouldn't expect to see with drugs that merely slow amyloid formation or even stop amyloid formation. There's a phase 3 trial which has been fully recruited, known as Deplete TTR-CM, and that's ongoing, and we expect the results to be published in the next few years, but that's certainly an exciting development. And one of the reasons for my excitement, certainly in terms of antibody therapy, is that a few years ago now, we discovered one patient initially and then two more out of our cohort of more than 5,000 patients who, in the absence of treatment, they didn't receive any disease-modifying therapy, they cleared their amyloid. They presented absolutely classically with very significant symptoms of heart failure, elevated NT-proBNP, classical imaging. One of them had a biopsy of the heart, which confirmed ATTR amyloidosis. The other two met the non-biopsy diagnostic criteria. They came back, it was during COVID, so they came back 2 years and 3 years later, and in some cases, and what we saw was complete resolution of their symptoms, with almost complete resolution of their imaging abnormalities, an improvement in their ECG, increased voltages on their ECG, a fall in NT-proBNP from over 5,000 in this patient to less than 400, but very marked in all three, improvements in NT-proBNP, a marked reduction in LV wall thickness and extracellular volume. So quite a remarkable reduction or improvement, spontaneous. And when we looked at what the cause might be, we discovered that all three patients had developed an antibody against their ATTR amyloid. And we looked at patients who behaved normally, in other words, who progressed, and none of 350 patients who progressed had an antibody against their ATTR amyloid. So we believe that this improvement that we saw in these patients was down to an antibody against ATTR amyloid, which is what is being tested in the trial that I mentioned earlier. So that's, I think it's very exciting. And the other proof of principle from this study, if you like, or these three patients, is that we didn't know if we achieved removal of amyloid from the heart, would that leave patients with a big baggy heart that doesn't do anything, or a fibrosed heart? And I think this is encouraging evidence to suggest that the heart has the capacity, at least, to recover if one removes amyloid. So certainly encouraging data. What about disease prevention? We're moving to the point now where we've been talking a lot about treatments, but what about trying to prevent the disease? And this is an ongoing phase 3 clinical trial that many of you will be aware of, using acoramidis in asymptomatic TTR mutation carriers who are within 10 years of the predicted age of onset of the disease. And they're randomized to either acoramidis or placebo, and the endpoint is development of the disease either on the basis of cardiac imaging or polyneuropathy symptoms and biopsy. So, the first prevention study in ATTR amyloidosis, really exciting. And finally, I'm going to just highlight a study that we've been conducting in the UK, which may also be amenable to prevention of development of heart failure. We took unselected individuals over the age of 50 with carpal tunnel syndrome who went for decompression, and we asked surgeons, rather than chucking what they excised in the bin, we asked them to make a block and send it to us for analysis for amyloid staining. And these were unselected patients, males, females, unilateral, bilateral carpal tunnel syndrome. And amazingly, we discovered that 39% of those patients had ATTR amyloid in their carpal tunnels in those biopsies. And of the patients who had amyloid in their wrists, we got them back for a cardiac evaluation, and we discovered that 28% of them had evidence of amyloid in their heart by DPD scintigraphy, and most of those patients had a grade 1 DPD scan, so early evidence of cardiac amyloid, and most of them were asymptomatic. A few were symptomatic, and we put a few of those patients directly onto tafamidis because of overt heart failure and classical symptoms, but most of them were asymptomatic. So a way into a pre-symptomatic population potentially for potentially administering some of these exciting drugs. The other thing that this study tells us is that there are more than 25,000 carpal tunnel decompressions per annum done in the UK in over 50-year-olds. And if you do the maths, it suggests that we really are, as Noel mentioned earlier, still only diagnosing the tip of the iceberg. And even more frighteningly, I heard the other day that only 20% of patients with carpal tunnel syndrome actually go for decompression surgery. So if you start doing the maths there, how many patients are there out there with this disease? It might be much, much more common than we think. So look, I'm going to finish just by highlighting a few unanswered therapeutic questions in ATTR amyloidosis. Firstly, existing silencers and stabilizers, which is superior? We don't know. There are no head-to-head studies. I showed you the data from our recent analysis suggesting that the drugs are broadly very similar, and I don't think we've got data at the moment to say that one stabilizes better than another, or indeed a silencer, vutrisiran is better than the stabilizers. What about acoramidis versus tafamidis? I showed you that acoramidis seems to be a better stabilizer in vitro, but does that translate to better clinical outcomes? Again, we don't have the data. There are no head-to-head studies. What about combination therapy versus monotherapy? I touched on that earlier. Well, we don't, again, have the data to tell us or to say that combination therapy is better or indeed not better than monotherapy. And perhaps that will come from CardioTransform. Does the degree of knockdown of TTR with the gene silencers or gene editing matter? Well, perhaps magnitude with its 90% knockdown or thereabouts, perhaps that will indicate better cardiac outcomes in ATTR amyloidosis. But again, that won't be head-to-head, and I don't think it's going to definitively answer that question. What determines regression of ATTR amyloidosis? I told you some patients regress very slowly, and some patients regress only slowly, if you like. So there are variable rates of regression between patients. We know that. What determines that rate? We don't know. How are we going to define non-responders? And that's going to become important when we soon have 3 drugs available to treat patients with ATTR amyloid cardiomyopathy. We already have multiple drugs for polyneuropathy. How are we going to define non-responders? And these panels at the bottom just show a study that we conducted recently in patients from our center, in which we were able to show that a progression of NT-proBNP over 12 months of greater than 700 and greater than 30% from baseline was associated with an increased risk of mortality. And again, amongst patients who had an increase in diuretic dose or needed to initiate diuretics, that was also associated at 12 months with an increased risk of mortality. And when you combine those two things, the patients who had both an increase in NT-proBNP and required more diuretics at 12 months had a threefold increase in mortality compared to the patients who didn't meet either of those criteria. So maybe a start of how we might define non-responders or progressors at least. And what about the role of supportive treatment? We've heard a lot about disease-modifying therapies. This is a study that was conducted by one of my fellows in which we took 220 ATTR amyloid cardiomyopathy patients on SGLT2 inhibitors. We propensity score matched them versus 220 patients not on SGLT2 inhibitors. The same proportion in both arms were on disease-modifying therapy in each group. And you can see better outcomes amongst those patients on SGLT2 inhibitors. We know that they're often associated with symptomatic benefit, but again, retrospective evidence, and I think we need to be a little bit cautious, but retrospective evidence that perhaps SGLT2 inhibitors not only benefit symptoms, but may confer prognostic benefit. So finally, I think it's an exciting time. As you heard from Noel, I agree that there are lots of exciting developments, and the developments have been pretty rapid as far as drug development goes. We've got 2 approved stabilizers that aren't necessarily quite funded in all of our countries yet, but 2 approved stabilizers. We've got 4 approved RNA interference therapeutics, and we're soon going to be testing a 3rd generation RNA interference therapeutic. We've got gene editing, which is being tested, and then we've got the so-called depleters, the drugs to remove existing amyloid. But I think, to leave one final message, I think with all of our existing therapies, the most important thing is to diagnose patients and diagnose them in the early in the course of their disease, so that we can start treatment earlier and improve outcomes. So thank you very much indeed for listening. It's been a great pleasure to talk to you today. I'd just like to finish off by acknowledging I've presented data from lots and lots of people, and many of my colleagues at the National Amyloidosis Center have contributed to that data. So I'd just like to acknowledge them. So thank you very much indeed.
Okay, well, thank you very much, Julian, for that fantastic overview and summary. Lots of things to talk about and think about. We have a few minutes for questions here for you, if that's okay. I mean, I could talk to you all day long, but we want to let you get on with your Saturday. I think we're coming up on Saturday evening where you are. So I'll see in our audience. I don't think you can hear, but I'll repeat the questions. So yeah, a couple questions, Patrick.
Yeah, so thank you very much, Dr. Gilmore. My question is in the context of earlier identification of patients and earlier initiation of treatment, and specifically when we're talking about magnitude and the Triton studies. So I was curious about your thoughts on preclinical data that suggests that liver-produced TTR can interact with LDL receptor protein 1 to shuttle beta amyloid out of the brain for degradation. So I was curious, is that a risk that's on your mind, initiating silencer or depletion therapies to earlier to those patients? Is that a long-term safety risk, in your opinion?
Could you hear that question, Julian?
I couldn't hear it, I'm afraid. I could just about make out that it was about is there any risk associated with low serum TTR levels, but I didn't hear the details.
Yeah, so I'll try to summarize that. So early recognition with respect to new data that supports LDL transport of amyloid, particularly with respect to neuro infiltration. And does that have any bearing on some of the new studies with respect to Triton? And did I summarize that well, Patrick? Or
If there's a microphone, I can ask it. Yeah, it's no problem.
why don't you come over here and just talk
I
into
think
my chest?
You want to unhook it?
I
I
don't know
think
how.
what I would say about the knockdown of TTR, I think it's worth bearing in mind that these drugs work on the liver, as you know, and they reduce serum TTR. But in terms of the TTR in the central nerves, that is really derived from TTR, which is produced centrally in in the brain, as it were, and serum or TTR in the CSF and in the brain will not be reduced by these drugs. So I think that's the first thing to say. And the second thing to say, I think, is that at the moment we have evidence based on on TTR knockdown in some patients of over 90%. It's a minority, but in some patients of over 90% for as long as 10 years. And to date, the data in terms of safety is extremely encouraging, and also in terms of efficacy, in terms of the nerves. So I think, I think we need to remain circumspect. Absolutely agree that we need to, we don't know if we knock out TTR by 98%, will we run into problems? But I think we need to remain optimistic but circumspect about if keeping an eye on what the developments will be.
Okay,
I
thanks
hope
very
that
much.
answered the question. Yeah.
Yeah, that was fantastic. Thanks, Julian, very much. Ryan, did you have a question? Yeah.
I guess it was about the attribute versus.
Oh, we
Thanks.
do have mics. Okay.
Thanks, Professor. Hello. Yeah. I don't know if you can. Can you hear me there? Or?
I can
Oh,
hear you
perfect.
very well now. Thank you.
Great.
Yeah. Yeah.
Thanks very much, Professor Gilmore. Ryan Davey from London, Ontario, the other London. So one question about attribute versus attract data, and that is that something I've never been able to wrap my head around is that, amongst many things, is that the 6-minute walk distance and KCCQ curves for the placebo versus treatment, okay? There seem to be more preservation of KCCQ and 6-minute walk in attract versus attribute. At least that's the way I looked at the curves. And I have a hard time understanding that if the attribute patients are more well. I don't understand why they appear to be losing 6-minute walk quicker than in attract.
Yeah, so no, it's a really good question. I think I think the first thing to say is that the placebo patients in those two trials behaved extraordinarily differently, particularly in terms of 6-minute walk test distance. So in attract, in the first 12 months, the placebo patients lost, I think it was around 45 meters, and the treated patients lost less, and there was a significant difference in the curves at 12 months, which is what prompted IDOS or BridgeBio to come up with that part A, expecting to see a difference at 12 months in terms of walk test distance. And in the attribute CM study at 12 months, the loss of walk distance in the placebo patients was, I think, again, I don't want you to quote the exact numbers, but it was in the region of 11 meters. So it was much, much less, from baseline, if you like, than the attract patients. And so there was no difference between the patients on drug and the patients on placebo, largely because the placebo patients behaved very, very differently. And I think that that's the important thing when comparing those curves, really, is that You know, the placebo patients, the difference, if you like, does not appear as marked because the loss in the placebo patients is far less. Do you see what I mean? Having said that, what I do completely agree with you about is the delay to seeing that difference between the two patients is quite marked, isn't it, in attribute CM? And you know, it would seem to be less so in ATTRACT, but I think that probably comes down again to the behavior of the placebo patients.
Thanks. I think it's more about, I guess what you're saying is it's more about how the curves look based on the way the math was done.
Exactly.
As opposed to the actual raw data.
Exactly. Actually, the loss, you know, the loss of walk test distance was far greater in ATTRACT than it was in ATTRibute, over, you know, in terms of absolute distance.
Great, thanks. We have time for one more question. Got a hand up over here. Why don't you go ahead? Actually, Ryan, can you just pass the microphone back?
This is Vaishali Sekharawala from Boston. Do you think that serum TTR level can be used as a screening method for TTR amyloidosis? It's a blood test.
Yeah. Great question. It would be nice if the answer was yes, wouldn't it? You know, but I think that there's, you know, we know that there's a huge overlap in patients with ATTR amyloidosis and non-ATTR amyloidosis, if you like, in terms of serum TTR. So I don't think it's going to be an effective biomarker by itself for, you know, presence or absence of ATTR amyloid. It might. So where one might be able to use it is in, for example, a patient with a thick-walled heart. If you measure serum TTR and it's low, that might push you a little bit harder to screen for TTR amyloid. You know, it could perhaps help the suspicion, if you like, of ATTR amyloidosis. But as a test to, you know, to say, has this patient got TTR amyloid or not, I don't think it's an adequate biomarker.
Great. Okay, thanks very much. Well, I want to thank you again, Julian, for, again, all your time and your insights and a fantastic overview. And again, just being a friend to Canada. You know, we've got a big baseball game going on in Canada tonight. So I think we're going to send you maybe a Blue Jays jersey or hat just to thank you for your time. But thanks again, Julian.
Thank you.
Always
it's
a
an absolute pleasure. Thank you very much.
Appreciated.
Thank you. Lovely to have a great day.
Okay, so we have a bit of a break now, and we'll reconvene at 10:45. So.